Moving on to our second session, I'm now going to cover some red blood cell indices, or statistics on red blood cells, as my students like to call them, that you should know as future healthcare providers. First of all, the first one I'm going to cover is hematocrit. This is a ratio, a way of describing the percent of red blood cells compared to the overall total volume of blood. So the picture here shown on the right is showing you how we calculate hematocrit, and you're going to be doing this in your first wet lab in class this week. If we measure the entire height of the whole blood column, then that would reflect 100% of the volume. And then if we measure the height of the packed cell volume, which mostly consists of red blood cells, we can take a ratio out of those two things. For example, let's say the whole column of blood here measures 100 millimeters, and the packed red cell volume measures 42 millimeters. We would then divide 42 by 100 to get a ratio or a percentage. In this case, because of the numbers I picked, it would be 42%. So men and women each have their own acceptable ranges for hematocrit. For our class, for testing purposes, we will pick 45% as our normal value for both men and women. That's a little bit high for women and a little bit on the low side for men, but it's a nice middle of the road average. Now, hemoglobin concentration. Careful with this one. As we progress through the semester, students oftentimes forget the definition of this one. Hemoglobin concentration is the weight of hemoglobin in 100 milliliters of whole blood. So it has the units grams percent. Now again, percent, that number, we think of 100. So in this case, grams percent refers to the grams of hemoglobin, the mass slash weight. I know that mass and weight are not the same, but here on Earth with gravity we tend to interchange them. So grams percent, and the percent refers to 100 milliliters of whole blood. Whole blood. It would not make sense to say 100 milliliters of plasma, and there's a question in your lab manual that asks you to write out the answer to this and explain why it doesn't make sense to say 100 milliliters of plasma. So for our testing purposes, we are going to pick 15 grams percent as sort of the middle of the road. It's about 14 to 16 if we take into consideration male and female. So for testing purposes, we're going to say 15 grams percent. 15 grams of hemoglobin and 100 milliliters of whole blood. Now, oxygen carrying capacity refers to the following. We can carry oxygen either dissolved in our plasma or bound to iron found in our hemoglobin molecule found in our red blood cell. The great majority of the oxygen that's transported by our blood is bound to iron. Therefore, we often want to know how much oxygen carrying capacity our blood has. How much can we physically transport in red blood cells? So in order to calculate oxygen carrying capacity, we need to multiply the grams percent of hemoglobin that we just discussed previously by 1.34 milliliters of oxygen for every gram of hemoglobin we have. So if we take our 15 or 16 grams percent or so and multiply by 1.34, we're going to get on average about 20 milliliters of oxygen for every 100 milliliters of blood. Now students oftentimes want to divide the 100 milliliters of blood into the milliliters of oxygen, and you can't do that. 100 milliliters of blood is not the same as milliliters of oxygen. So that 100 milliliters of whole blood stays in the equation. So the end units are milliliters O2%. Those are the correct units. So milliliters of oxygen for every 100 milliliters of whole blood. Now, the other red blood cell indices that I want you to know are the following. Mean corpuscular volume, or MCV. There is a range again for this normal, for the volume of a red blood cell. That's what I'm referring to. MCV is the volume of a single red blood cell. And back in earlier days of medicine, they used to refer to the red blood cell as a corpuscle. So that's why that word is there. So MCV, for our testing purposes, we're going to pick 100. 100 microns cubed are the proper units. Mean corpuscular hemoglobin, or MCH as it's abbreviated, is the following. If I could take a single red blood cell, shown here to the right on our picture, and crack it open and actually detect or measure the amount of hemoglobin in that single red blood cell, the normal values are 32 picograms. Now, let me explain the units that you're seeing on the screen here. Another way of writing 32 picograms, a picogram is 10 to the negative 12th. Now on my screen it says 10-12. That negative 12 should be superscript. So a picogram is 1 times 10 to the negative 12. So we would have 32 picograms of hemoglobin in a single red blood cell. Another way of writing that would be 32 micrograms. Some textbooks actually write it that way. I will write it 32 picograms, which is abbreviated little p, little g. Mean corpuscular hemoglobin concentration. This is the overall percentage of hemoglobin in a single red blood cell compared to its volume. So, for example, if I were to take the 32 picograms and divide it by 100, which is the volume of the red blood cell, I would get roughly 32%, right? Well, in my mean corpuscular volume, I gave you a range, 80 to 100. So if I divide the 32 picograms by a number a little less than 100, say, 90, then I would get a higher percentage. So mean corpuscular hemoglobin concentration is 34%. Again, this is the ratio of the mass of hemoglobin compared to the total volume of a single red blood cell. Let me put it to you another way. We have roughly, let's say we have about 100 students in our class. We don't, but let's just pretend we do. If I asked you, what is the ratio of women compared to this whole volume of our class? Let's say we had 34 women in our 100 students, then the women would comprise 34% of our class volume. So again, mean corpuscular hemoglobin concentration is a ratio, a way of describing the mass of hemoglobin compared to the volume of a single red blood cell. So it's a solute to solvent kind of ratio. Mean corpuscular diameter, or MCD, is how wide a red blood cell is. And for our class, it's 7 to 8 microns. We're going to pick the middle of the road. We're going to say 7.5. The color index is a way of referring to how red does a single red blood cell look. If it's adequately filled with hemoglobin, if a red blood cell has its full 32 picograms of hemoglobin, then we say the red blood cell has a color index of 1. If the red blood cell was filled with only half of its normal hemoglobin, well, then the color index would go down to 0.5. Again, this is a way for hematologists to look at a red blood cell, assess how red it looks, to give an indication of how well filled it is with hemoglobin. Is it fully filled? Is it looking very pale red, and therefore the red blood cell only has half the hemoglobin in it that it should? Again, it's a very subjective number. So our normal class value will be 1. I know there's a range on the screen, but we're going to say 1.0 is our normal class value for the color index. Now moving on to some terminology. When I speak of chromasia, this is an indication of the mean corpuscular hemoglobin, the amount of hemoglobin in a single red blood cell. And again, if a red blood cell is adequately packed with hemoglobin, then it should have a nice red color. So again, chromasia is really a way of saying the color index, which is a way of us assessing how much hemoglobin is in that red blood cell. So a red blood cell with the normal amount of hemoglobin would have a color index of 1.0, and we would say clinically it's normochromic, meaning it looks as red as it should. Can a red blood cell be hypochromic? Yes. In this case, it's not adequately filled with hemoglobin and therefore looks very, very pale, as shown in the top left picture here. Hypochromic anemia. You can see they look very faint. Now, can a cell be overfilled with hemoglobin? Can a red blood cell actually be overpacked? And that doesn't really happen. But I'm going to give you a quirky instance called hereditary spherocytosis, where the red blood cells initially are formed well and are filled well with hemoglobin, but over time the cell shrinks in size. And so therefore the hemoglobin, the normal amount, now becomes packed in a smaller volume. And so in that case, the red blood cells can look more red. But technically speaking, there is no way to pack more hemoglobin in a red blood cell. Again, the quirky one, I'll explain hereditary spherocytosis. The cells are made normally initially, but over time they shrink, and then the hemoglobin inside them gets packed in a smaller volume, and then the cells look like they are hyperchromic. Anisocytosis. Cytosis refers to cells. Anisocytosis is a way of indicating mean corpuscular volume, or the size of a red blood cell. Microcytic cells are small cells. Macrocytic, or sometimes referred to as megalocytic, those are large cells. Normocytic would be a red blood cell that has its normal size and diameter. So again, it's an indication of the mean corpuscular volume. Poikilocytosis refers to the shape of the red blood cells. Are they normal in shape, or do they have abnormal shape? So sickle cell anemia, shown in the top right picture, you can see the cells have a half moon kind of crescent shape to them. That is the sickle cell shape, and that's a type of anisocytosis. Shown, not shown here in this picture, is spherocytosis, where the cells are perfectly round instead of having their biconcave disc-like structure. And then there are red blood cells that look like they have spines on them, like an echinoderm, or what you might associate with a sea urchin, if you will. So those are called echinocytes. Again, chromasia, color, the amount of hemoglobin in a single red blood cell. Anisocytosis refers to abnormal size of a red blood cell. Is it microcytic or macrocytic? And poikilocytosis refers to its abnormal shape. Instead of being a biconcave disc-like structure, the cell looks like it's a half moon, or perfectly round, or has spines on it, just to name a few. Now, other red blood cell properties. The red blood cells are the most abundant cell in your body. I have said many times you are 100 trillion cells big, and a quarter of those cells are red blood cells. So you have 25 trillion red blood cells in your body. If I were to take a drop of your blood, and for me a drop of your blood is about the size, if you were to look in a textbook, at the end of a sentence you would see a period. Well, if you could turn that little black dot into a sphere, that would roughly be the volume that a microliter would fill. And it's hard for students to even comprehend that in that tiny little dot, you would be able to, you would count about 5 million cells in that tiny microliter. So we have about 4.5 to 5.5 million, 10 to the 6 is million, cells per cubic millimeter. And another way of saying cubic millimeter is microliter. So it's daunting to think of. The red blood cell shown here in this top right picture is folded over on itself. I told you the mean corpuscular diameter is about 7.5 microns, and that is still too large for red blood cells to get through a typical capillary bed. So the biconcave disc shape allows a red blood cell to kind of fold over itself so it can shimmy its way through a capillary bed. So the biconcave disc allows a red blood cell to bend and flex while going through capillaries, but also a biconcave structure allows for an increase in surface area, and this will allow a greater rate of diffusion. Later on in the class, you're going to learn about the Fick's law for the rate of diffusion. Many things will dictate how quickly something will travel from one spot to the other down a concentration gradient, and surface area is one of those components for Fick's law for rate of diffusion. Red blood cells are mostly filled with hemoglobin. It is the most abundant substance found inside a red blood cell. But students oftentimes think erroneously that that's all a red blood cell has, is just hemoglobin, and that is not true. They have an aqueous environment inside the red blood cell. They have intracellular fluid just like all the other cells of your body. And there are other components dissolved in that cytoplasm. There are glucose molecules, there are enzymes, there are other things besides hemoglobin, but hemoglobin is the most abundant substance. So I think of red blood cells as bags of hemoglobin, but that's not all they have. And this hemoglobin is going to be important for not only transporting oxygen, but hemoglobin also binds to carbon dioxide. The carbon dioxide simply binds to a different region of hemoglobin than where oxygen binds. Now I have a homework assignment for you all. And it's shown here in this bottom right picture with this man in the bathtub. And it helps students to understand the following concept. If I were to fill up my bathtub halfway full, and if I opened the drain so that the amount of water leaving my tub is matched by the amount of water coming into my tub through the faucet, then my bathtub will remain halfway full. If I let this occur overnight, which is not responsible for water usage, but if I were to allow that to happen, the next day I would come in and my bathtub would still be half full. But the water that's in it is not the same as the water that was in the tub the night before. There's a steady turnover. The same concept applies to your blood. If I were to draw your blood today, and then a week from today, you should have roughly the same number of red blood cells. But in that week, you would have had new red blood cells entering the circulation from the bone marrow, but you also would have had removal of aging, dying red blood cells by the liver and spleen. So that goes along with my bathtub analogy. The next day, I still have the same volume of water, but the individual water molecules that are in my tub at that moment are different than the ones that I had the night before. What is hemoglobin exactly? Hemoglobin consists of 4 individual proteins associated with each other, the quaternary structure. There are two alpha units and two beta units, and these are proteins, so therefore they are products of gene expression. And the genes for the alpha subunits and beta subunits are found on different chromosomes, and I'll explain the chromosomes that they're found on in another segment, or soon, I should say. Each chain, each hemoglobin chain, if you look at the top right picture, has this orange disc-like substance in the middle of it. Now that's called a heme group, and a heme group consists of two things. It contains the circular disc-like structure called a pyrrol ring, and in the middle, shown as a red dot, a red sphere, is iron. When you have both of those assembled, then you have heme. Now, it is the iron ion in the heme complex that binds to oxygen, and it binds in a reversible manner, meaning it can bind to oxygen and then let go of the oxygen. And students oftentimes think, well, if it is the iron that binds to oxygen, why do we need all of the protein chains? Why do we need the alpha and beta chains? Why can't we just use iron to transport oxygen? And the answer is, if we only used iron, the iron would bind to oxygen so tightly that it would never let go of the oxygen to the tissues of the body. It would bind in an irreversible manner. So then your next question as a student would be, what actually dictates the iron to bind to oxygen and let it go then in the tissues? And the answer is, it's the beta and alpha globin chains that are going to dictate the reversibility of the iron binding to oxygen or letting it go. So in the lungs, the globin chains allow iron to bind to oxygen, and in the tissue beds of our body, the globin chains cause the iron to let go of the oxygen molecule to the tissues. Now, my question in the yellow text box is, how many oxygen molecules can a single hemoglobin molecule bind? And the answer is, well, we've got 4 heme groups, 4 iron centers, and that means 4 molecules of oxygen. Okay, so here is where I'm going to address the globin chains. Again, they are going to dictate the reversibility of iron binding to oxygen. We cannot just use iron alone to transport oxygen. Iron alone would bind in an irreversible manner, and our tissues then would not get their needed oxygen released to them. So again, the globin chains dictate hemoglobin's affinity for oxygen. They are going to dictate the positioning of iron in that pyrrol group and either allow iron to bind or release oxygen. Very, very important. And it won't be until the last lecture unit where I explain to you on a molecular level exactly how the globin chains do this. We need a lot more lecture time between now and then for you to appreciate that story. Again, the globin chains are found on chromosomes. They are products of gene expression. The beta globin chains, their genes, are found on chromosome 11, and the alpha globin genes are found on chromosome 16. We actually have 4 genes that code for the alpha subunits, and the beta genes follow a typical Mendelian genetics. We have 2 genes. These genes are expressed throughout life, but we express different globin chains. Again, the adult hemoglobin is alpha 2, beta 2, but when you were going through embryogenesis, and again, blood during embryogenesis is synthesized by the yolk sac, you used different globin chains for your erythropoiesis. You had alpha 2, epsilon 2. So I remember epsilon as being E, and I remember that for embryonic. Then during your fetal development, when your blood cell synthesis shifted to the liver and spleen, you again made different globin chains for your hemoglobin. In this case, it's alpha 2, gamma 2. And then shortly before birth, you started to shift into the adult hemoglobin, which is alpha 2, beta 2. Now, why do we have different types of hemoglobin through embryonic and fetal stages and then finally the adult form? And the answer is, when you were going through embryogenesis, your placenta was not well formed. And you were getting your oxygen from your mother's red blood cells. That meant the oxygen had to be released in the uterine lining and then diffuse all the way to where you were, the embryo. So you needed to have a hemoglobin with very, very high affinity. This might be a new term for you. Affinity refers to the binding of something, holding on to it. So you needed a hemoglobin that had a stronger attraction for oxygen so that your mother's adult hemoglobin released it into the tissue and your embryonic hemoglobin bound to it quickly to distribute then to your developing tissues. Then in your fetal development, you now had a placenta that was well formed and you didn't require such an aggressive, if you will, type of hemoglobin. You could shift to a somewhat lower affinity, but you still needed a hemoglobin with a higher affinity than your mother's, so that her hemoglobin would release the oxygen and it would diffuse into, again, your red blood cells so that your red blood cells could release the oxygen to your developing tissues. You weren't breathing at this point, so all of your oxygen was coming from your mom, and it had to shift from her red blood cells to her tissue into your tissues and your red blood cells. Then again, shortly before birth, you started to make the adult hemoglobin, with the idea being soon you would be breathing on your own and you wouldn't require such a high affinity hemoglobin. Now, where are the pyrrol rings made? They are made in the mitochondrion, and you do not need to worry about the ingredients for a pyrrol group like succinyl-CoA and glycine. I just want you to know that we take these pyrrol groups and we assemble them into a ring. And when the ring does not have iron in it, we say it's a protoporphyrin ring. Then when you add iron to the center of it, as shown here in the green circle, now we can call this entire structure heme. Then when we take a heme group and insert it into either an alpha or beta polypeptide, then we have a hemoglobin chain. When we assemble 4 hemoglobin chains, 2 alpha and 2 beta, then we get adult hemoglobin, shown here as hemoglobin A. A is for adult. So there are a lot of terms to know for the construction of these things. Again, pyrrol groups assemble into a ring. We call it a protoporphyrin ring. When we add the iron to it, then we call it heme. When we put the heme into the polypeptide, now we have a hemoglobin chain, either alpha or beta. And when we assemble our 4 chains together, we have adult hemoglobin. Iron. Iron is the ingredient we find in hemoglobin. Iron, of course, is a transitional metal. It can have different ionic values. It can be either a +2, which means it's lost 2 electrons, or a +3 form. The +2 form is the ferrous form, and the +3 form is the ferric form. It's the ferrous form that can bind to oxygen. So if I think of ferrous helps us, that helps me remember that it is the reduced +2 version that binds to oxygen. Ferric cannot bind to oxygen. So if our iron becomes oxidized, we need something that can give it an electron and reduce it back into the form that can bind oxygen. And students oftentimes say, well, does that even happen? Yes, it does happen. If you're exposed to pesticides you can have your iron easily go in the ferric form. And iron in this form, in hemoglobin, we call that type of hemoglobin methemoglobin, and it cannot bind oxygen. So yes, inside the red blood cell are enzymes whose job it is to deliver an electron to iron when it is in the +3 state, to reduce it back down to +2 so that you can carry your oxygen. Now, where do we get iron from? We get it from our diet, and we get iron in our vegetables, but if you cook with an iron skillet, you get iron in your diet that way too. So it's very good for you to cook with an iron skillet because it's a great source of iron. Now, when you absorb iron into your plasma, it turns out it doesn't like to be free. You need a plasma protein to shuttle it around. This plasma protein, when it does not have iron bound, is called apotransferrin. When iron binds to it, we drop the prefix apo, and then it's called transferrin. Then, when the iron gets to cells of your body, say cells like the hemocytoblasts in bone marrow or the liver, there needs to be a intracellular protein whose job it is to bind to the iron and store it. Now, the protein inside the cells, when it doesn't have iron bound, it's called apoferritin. When iron binds to it, then it's called ferritin. So ferritin is the healthy way for cells to bind and store iron for future use. If there is too much iron in the diet and too much iron absorbed, and I'll talk about this, iron can actually start to be stored in cells in a very unhealthy, toxic way called hemosiderin. It's extremely insoluble. The iron literally precipitates out of the cytoplasmic fluid, and it kills cells, and we see this happening in a condition, a disease called hemochromatosis that I'll talk about in just a bit. And it literally kills organs because the cells are dying from this toxic way of storing iron. So hemochromatosis, like I said, is iron overload in people who have a mutation in a gene found on chromosome 6, and it leads to their gut absorbing much more iron than normal. Normally we absorb about 10% of the iron we ingest. In these people, because of their recessive mutation, they end up absorbing about 30% of the iron in their diet. This leads to hemosiderin inside their cells, and it leads to organs dying from the cells dying. It's organ failure at its best. They present with a classic triad of signs. They have bronzed skin from the excessive iron in their diet, gives them kind of like an orange look. They have hepatomegaly. They have an increased liver size. That's what hepatomegaly means. It's from the liver trying to detoxify the iron. It gets larger, more hepatocytes, but the liver is actually becoming filled with scar tissue as the hepatocytes die. That's cirrhosis. There are elevated liver enzymes. And the third thing that they present with is diabetes mellitus, because the pancreas also starts to die, if you will, from this iron overload. So we say they have bronze diabetes. Let's see, in addition to profound organ failure because of the excess iron being stored in the liver and the pancreas, the heart is also at risk, heart degeneration. We're going to see arrhythmias present. But the person also presents with pain in joints and their abdomen, and they have chronic fatigue, and they oftentimes complain of vertigo. Again, it's from all cells of the body accumulating this iron and the tissue starting to degenerate. Now, where does the stimulus come from for red blood cell synthesis? Well, first of all, you've heard me say, in my humble opinion, the kidney is the crankiest organ in our body. And the reason why I say this is because the kidney really is monitoring many substances in the blood and will send out signals and even hormones to cause changes in the body based on what data it's gathering. We talked about reflex arcs being involved in homeostasis in our first lecture. So the kidney in this case detects the amount of oxygen in the blood. If the kidney does not detect enough oxygen, if the kidney is detecting hypoxemia, hypoxemia is the amount of oxygen in the blood, again, emia means in blood, then the kidney will release a hormone called erythropoietin. Now the kidney is the largest source of erythropoietin. 90% of the erythropoietin in our body comes from the kidney. The other source is the liver, but it's only minimal amounts. And the erythropoietin will stimulate the hemocytoblast to replicate and divide more quickly, and will also influence more daughter cells going through the myeloid stem cell line, specifically the erythrocyte cell line. So it promotes the mitotic division of the hemocytoblast. That's what I say here, stimulates stem cell mitosis. It promotes more of the daughter cells going through the red blood cell lineage. It promotes an increase of reticulocyte release, and I'll remind you that's normal. The red blood cells are released into the bloodstream in an immature form. The reticulocyte still has some endoplasmic reticulum. And in the next few days, you would see an increase in red blood cell number. Now, let's talk about if someone were to have kidney failure. If you have a patient with kidney failure, I'll remind you that the greatest source of erythropoietin is the kidney. So another side effect of this kidney failure is going to be a decrease in erythropoietin, and the patient is going to present with anemia because of the reduced amounts of erythropoietin being released. Now, I told you in an earlier segment that, at least I think I did, that our normal value of hematocrit, the number of red blood cells, the percentage of them in whole blood, should be 45%. Now, in the competitive athletic venues, cycling, just to name one, of course, it would be an advantage to a person to have more erythropoietin and have more red blood cells, more oxygen carrying capacity, and therefore be able to maintain an aerobic state longer and win the race. So when someone blood dopes, one way to do that is by injecting synthetic erythropoietin. Well, we now have the way to make recombinant human erythropoietin, which means in the athletic world, it would be easy for someone to blood dope with that, and it would not be detected by a typical drug screen. So a lot of competitive athletic venues now are saying, fine, we might not be able to catch you if you blood dope, but now we're putting a limit on the hematocrit percentage. If your hematocrit is more than, and I'm picking a number, 55%, then you cannot compete. It's as if these athletic venues are saying, fine, we give up. If you're going to blood dope on erythropoietin, we can't catch you, but if your hematocrit goes more than 55%, that's when you are not going to be able to compete in our cycling race, just to use an example. Last slide for this segment, again, is showing you the reflex arc involved in red blood cell synthesis and how the kidney is monitoring this. If the kidney detects low oxygen content, say if you were going to the top of K2, which is the mountain I'm showing you here, there's reduced oxygen content in the atmosphere at that higher elevation. The kidneys would detect less oxygen in your blood because you would be breathing less of it. The kidneys would detect this hypoxemia. They would release more erythropoietin. This stimulates the hemocytoblasts and promotes more red blood cell synthesis and release of the reticulocytes into the bloodstream. So if you were to stay at base camp as you were hiking K2 for, say, a week, you would acclimate, and within a week you should have more red blood cells, and then you can climb to a higher region of the mountain, say base camp 2, and then acclimate for another week. That's basically what these hikers do when they are going to K2 or Mount Everest, to give you another example. Alright, so how else can a patient have reduced oxygen content in their blood if they're not hiking to the top of a mountain? Well, maybe they have pulmonary disease where there's a problem with their pulmonary lining and they cannot allow adequate amounts of oxygen to diffuse. Maybe they have a chronic obstructive pulmonary disease that is inhibiting that oxygen exchange. Or maybe they have reduced numbers of red blood cells. Maybe they have a condition, a type of anemia. Or maybe they've lost blood because they've had a severe hemorrhage. These are just a few ways where a person can have a reduced oxygen content without hiking to the top of a mountain. Okay, on to section 3.